Mm. Mm.
Did you hear a noise, Daniel?
I did hear one. Is everything okay?
Yeah, but it's gone now.
Okay.
Hey, Danielle.
Yes.
Is my background back to front? It's back to front, how I'm seeing it.
No, you're back. You will see it back to front for you, but
Oh.
it's correct for everyone else.
Cool, thank you.
Good afternoon, everyone. Welcome to the Be Brave, Make Channel Change panel. Very excited to see everyone joining. So I will be displaying the slideshow. We'll have this cover page, and next I'll go through some, I guess, house rules, participation etiquette. So I'm going to press next on my slideshow. Can I confirm everyone can see the slideshow on my screen? Yep, everyone seems to be nodding. Fantastic. Okay, so I am going to go through that now. All right, so ensure you're on mute to avoid disruption. Be aware of your camera and microphone settings throughout the panel. Use video where possible. It can give you a more satisfying experience and help you and your colleagues feel more connected. And to keep the presentation and discussion moving, please type your questions in the chat. We will try to get to all your questions or comments as we move along. And now I will pass it on to Danielle.
Thank you, Erin. Hi all. It's good to have you in the space with us. National Reconciliation Week is a time for all Australians to learn about our shared histories, cultures and achievements, and to explore how each of us can contribute to achieving reconciliation in Australia. Before we start, I want to acknowledge that 2022 is marked by significant national anniversaries of Brave Action. 50 years ago, the Aboriginal Tent Embassy across the road from the Parliament House in Canberra started. 30 years ago, Mabo High Court decision was made that recognised the rights to land. And 25 years ago, the Bringing Them Home report on the stolen generations was released. I want to further acknowledge that we meet on Whadjuk country. And if anyone else is tuning in from a different country within WA, we further extend that acknowledgement to realise the brave actions of our colleagues. And as we continue to act with bravery, that we continue to pay respects to elders past and present. This panel has been designed to address the 6 strategies that community have asked us to work towards. You'll see them on the slide right now, if you're not familiar with what they look like. They're highlighted in the Department of Health Aboriginal Health and Wellbeing Framework and in the recently released North Metro strategy, which is a whole of North Metro approach to working through these strategies. Very important and documents to get your head around. On today's panel, we have Pushpa Sivakumar from WIN's dietetic team, corrections from diabetes. Apologies to you and your team, Pushpa. We also have Dr. Scott White from WIN's preterm birth clinic. We have Kylie Lawton from SARC, Grady Coyne from Wanders, Storm Motahata from North Metro Workforce, and Kelly Cameron from Breast Screen. This space is a space for you to be interactive with us. So please do ask your questions. Please do make comment if you like. And know that we will be making a social media post. So if anyone, the recording won't go out on social media, just a post saying that we have done this. And if anyone has any objections to having their photo in that on social media, please do put it in this chat and we'll make sure that we pay attention to that for you. Okay, so in no particular order, let's get into today's discussion. So we'll turn to Pushpa first. And we'll look into we'll look into
I didn't realize I'll be the first one, Daniel, but that's okay.
You're right off the bat. So yes, we're going to turn to Pushpa. Thank you for being the first one, Pushpa. And we're going to look into one of the strategic directions, the strategic direction to promote good health across a life course. What they're saying is the strength of using a life course approach is that it focuses attention to the broader factors affecting health and well-being as people move through their stages of life. And by applying a life course approach, it supports the identification of key transition periods to provide a point of intersection between health, mental health, and social emotional well-being. So do you know of a success outcome that utilised the life course approach? And can you tell us about what was done to make this happen?
Okay, thanks, Daniel. Can you all hear me well? Yeah, okay. So I do have a successful story to share with you guys today. So it's all about a patient journey at King Edward. And for this purpose, we will name this patient, de-identify and name this patient as Amy. I love the name Amy, so I'm going to call her as Amy. And so Amy lives in the Aboriginal community in Carlisle in Perth Metro. So Amy was brought into King Edward in April this year. So this is an incident that happened recently and a successful story for King Edward. So Amy, from the life course approach, Amy is obviously in her adulthood stage. And the reason why Amy was brought into the hospital was she was pregnant, but she had a very complicated pregnancy. She had pre-existing problems, type 2 diabetes, and she was morbidly obese as well. So obviously we know that being morbidly obese and having poorly controlled type 2 diabetes can lead to poor outcomes in pregnancy. And she also had a traumatic birth history in 2020. Obviously, she gave birth preterm, around 29 weeks. I think it was 29 plus 3. And she also had the history of FDIU, fetal death in utero, which is really not good sign at all for this pregnancy. Also in this pregnancy, syphilis was detected quite earlier on, and that is another not a good sign. So now what happens is a few years ago in King Edward, a preterm birth clinic was started. When I started working at King Edward, that clinic was not there, but it was started recently. I'm guessing maybe between 5 to 7 years, maybe. So it started, and preterm birth clinic just kicked in very earlier on in Amy's pregnancy. And she was brought in, and they also found that her poorly controlled type 2 diabetes was leading for the baby to grow big. And they felt that, multidisciplinary team should involve in her care. So dietitians were called and asked to intervene in her care, mainly to look at her diabetes control and make sure her glycemic control is good, and also to avoid excessive weight gain in pregnancy, which is needed, for good outcomes of pregnancy. So not only the dietitians, preterm birth clinic also involved the diabetes educators, clinical psychologists, social workers, physios, and also ALOs, Aboriginal liaison officers. So mainly the multidisciplinary team was involved to cement the education in multiple ways and address the intersections between the patient's health, mental health, emotional health, and social well-being. So ultimately, the success story is, so we provided all these service to her, and we intervened as early as possible, and she had excellent outcome in her patient journey. And Amy, this pregnancy, this time around, she delivered at 37 weeks, whereas her previous one was at 29. So this time it was 37 plus weeks. But obviously, because of her poorly controlled type 2 diabetes and her morbid obesity, the baby was a bit big. When I say bit big, the baby was 4.8 kilos, which is big. But at 5 minutes, the APGAS was quite good and just had a little bit of slight bit of grunting and was taken to the nursery. But baby got discharged with mum when mum went home. So that was really a success story for us, for King Edward, for Amy, for all the clinicians, and for everyone. So the take-home message or the highlight of this story is Amy was in the right place, right time, with right people, and with right intervention. So that's probably what she needed, and we all did a part, and she had a successful pregnancy outcome. So that's pretty much what I would want to say for this strategic direction of life course approach.
Beautiful. So that's back to me, you'd say?
Yeah.
Yeah, wonderful. It's nice to hear that that the way that we're working currently is actually producing success for patients that come through our service. And what I heard you say is basically when we consider, when we don't isolate the situation for what's going on now, and we consider all the things that has happened for that person, then we know exactly what it is that in terms of the type of service that they need to have a successful pregnancy or birth in this case. And the fact that you've wrapped around and you've brought in a multidisciplinary team is how you went about that and made it happen. Seems like two really, really simple sort of things to be including into our practice. And I just acknowledge your team for assisting that lady through that process and giving her a better experience from her first one. So congratulations to you and your team. We will turn that to the audience. Has anyone got any questions? Aaron, did anyone put anything up? Any questions, comments to that strategic? Is there something that that has not happening on your end that you'd like to bring to the space right now?
No questions as yet. So yeah, absolutely open to anyone to pop something into the chat if they wish to.
We'll give a little moment, that awkward teacher wait. No, awesome. That's good. So if we can all learn from Pushpa's team, intervene early. It worries me that this case was, and I will mention this, that this case was successful because it was a right time, right place, right people, right intervention. And how do we make sure that the system is ensuring that the right people, right place, right interventions is always happening and it's not reliant on the person. I'll just put that out there for food for thought. Okay, so we'll move to the our next panelist, Dr. Scott White. We're going to bring you in. And we're going to look at the street. It's a nice little flow on from Pushpa mentioning the preterm birth clinic. And this strategic direction is focusing on the prevention and early intervention. But what they're saying is when we invest in preventative actions, it's less expensive and has positive impact on health outcomes compared to treating symptoms which is more costly and has a lower rate of success in improving health outcomes. They say that there is a role for prevention to build Aboriginal people's capacity to engage with and adopt healthy lifestyles through increased health literacy. And they also say that Aboriginal people can be supported to develop knowledge, attitudes and skills to choose healthy lifestyles, promote healthy environments, and also address lifestyle risk factors. So the question for you, Dr. Scott, is, can you tell us a story of when the role of prevention has been used to promote a healthy outcome?
I can. Thank you. Kaya, Danielle, thank you for the invitation to speak today. And I wanted just to quickly acknowledge that we meet here on Wajak Noongar Budja, and I pay my respects to elders past, present and emerging. And as I'm doing a bit of work with a group of Aboriginal elders and some of the stillbirth research that I do, and I'm really enjoying getting to learn a lot more about Noongar culture. And one of the things that I've learnt in the last couple of weeks is, and I'm going to say this wrong, but I'm going to try because it's important, is this concept of Jindal Mawit. These are star babies. And this is something that Auntie Millie Penny talks about. And Aboriginal people, Noongar people, call these star babies as the babies that have been lost to stillbirth. And I accept that this and acknowledge that this is a confronting topic to talk about, but it's an important one. Why? Because Aboriginal women lose their babies at twice the rate that non-Aboriginal women. Yeah, and it affects not just Aboriginal women; it affects their entire families and their entire extended communities. And we know how important that family is as a construct to Aboriginal people. And when I think, I'm going to tell you a story because I've been inspired by Pushpa to tell you a story about an individual patient. But when I think about this woman and her family, and she comes from a remote community up in the Kimberley, and I can imagine her sitting there outside gazing up at these stars. And this woman, 6 of those stars are her little star babies. So this woman, Davina, I'm sure she wouldn't mind me using her name. Davina is one of my favourite patients. Davina lost 6 babies to stillbirth and preterm birth. So 6 little babies that she lost in the mid-trimester before any of them were big enough to survive. And she'd done absolutely everything that she could, and everything that we'd asked of her, and we'd tried all the interventions that we had without any success. And in in Davina's, not her last pregnancy, but the one before that, she was brave. She made a change. She brought herself down to Perth for the entirety of that pregnancy, really uprooted herself from her community and off country, which is obviously a confronting thing for her to do, and put her faith in the service that we could provide, perhaps more than we deserved, because we really didn't know what to do. As a last-ditch effort, we did a special operation for Davina, and we looked after her as closely as we could through that pregnancy, and it was our absolute delight when she got to take her beautiful buffy term baby home. And that was great. And the thing that made it even better is when she came back to us with her next pregnancy, and she did exactly the same thing again. So poor Davina, who lost 6 of her little star babies, came back and now has 2 beautiful babies. And Davina's just the greatest example of a strong Aboriginal woman who'll do what she needs to do for her family. But just to highlight what you've told us about, Danielle, and what you came to just before you asked me to speak, is that we have these resources, we know what we need to do, but accessing those for our Aboriginal sisters is the challenge. Yeah. So equity of access is a major problem, and it's why we see such a disparity in pregnancy outcomes in our Aboriginal and non-Aboriginal women, and it's something that we really need to. So we know what we need to do, we just need to do it better. And so we've had some success in this space. In fact, we've had a lot of success in this space, and we need to give ourselves credit for that. So in 2014, our group, led by Professor John Newnham, rolled out the West Australian Preterm Prevention Initiative, and that initiative was to aim to safely reduce the rate of preterm birth across our community, and we had excellent success with that. So the rate of preterm birth in the first year of implementation came down by 8%. There were 200 fewer preterm babies in that year compared to what we would have expected. So really good success. Here at King Edward, we were even more successful. Our rate of preterm birth came down by 20%, and it's stayed like that now for the last 6 or 7 years since that program went up and running. So really good success. So yes, we're doing positive things. Problem is, we've not had that same success in Aboriginal women. The Aboriginal women's preterm birth rate, which is already double that it is in non-Aboriginal women, hasn't changed. So the challenge that we have, the opportunity that we have, is to be able to translate the successes that we have in non-Aboriginal women across to our Aboriginal women as well, and our Aboriginal families as well. And why is that so important? Those of us who work in pregnancy, those who work in fertility and maternity and all the allied health features that go with that, have the greatest opportunity to make change, because we don't affect just one person. We affect entire families, entire communities with the work that we do. And we get someone at the earliest point of their life, before they're even born, So we can impact that person not just for a few years at the end of their life, we can impact that person, their community, for their entire life. And the other thing that we do is that we know pregnancy care, preterm birth prevention, stillbirth prevention, for all of the other preventive things that we do in pregnancy, has the capacity to impact not on that woman, not necessarily on that baby, but on that baby as it becomes an adult as well. And it's a real opportunity to affect intergenerational change, to hopefully reverse some of the intergenerational trauma that we've seen that has landed us in this situation in the first place, where we see such a dreadful disparity in health outcomes for Aboriginal and non-Aboriginal people. So there's a big challenge, absolutely, but with big challenge comes great opportunity, and I think the theme of reconciliation this week, this year, be brave, make change, speaks to us all. That we can be brave, we can make the changes that we know need to happen, so that we can improve the health for these women and their babies and their families. Thanks, Danielle. Back to you.
Thank you, Scott. I got a bit of feedback. Someone's no, cool, we're back. Beautiful. So what I'm hearing is that there's still quite a lot of work in that space that needs to happen when it comes to being able to name that we are successful. But we do know that what is the way of getting into that success, and it's about connecting with the community and working with them, but also going out and getting it, transferring that across to wider than the person, so that, because it is about affecting more than just the person, basically, is what you're saying. And I don't know if everyone else in this room is starting to sense. We've only gotten to the second panelist right now, and I don't know if you're noticing that we're starting to feel or get a sense that these strategies may have a lot of overlap, and they may actually be tied into, we're kind of just isolating them, and then they happen in every sort of situation. So we've got to be able to weave each and every single one of these strategies in the one type of work that we do. We'll continue to go through, and we'll see if that surfaces a bit more and proves to be true. So the next person that I want to bring into the space is Grady. Grady, we'll bring you into the space now, because I actually got a little bit confused or torn after hearing from you, Dr. Scott, because you mentioned two things around working with the community, but you also talked about finding ways to make the services equitable as something that's important as well. And they are two other strategic directions that do exist in the 6 that we are committed to. So I will go to you, Grady. The strategic direction that you're looking at is the individual, family and community well-being. So what they say is strong, resilient families and communities can prevent illness, responding in timely manner to respond in a timely manner when illness occurs, care for and manage chronic illness that impact on family, and reduce the chances of hospitalization, So basically, working with the families can help to reduce a lot of that. So strengthening the family system of care forms the basis of innovative approaches to improving future health and well-being for Aboriginal people in that same instance when we work like that. So the question that I have for you, Grady, is how does your unit identify strengths and utilise resilience in the family to get good outcomes for the patients and baby?
Thanks, Danielle. Thanks for having me today. I really appreciate it. I work with the Women and Newborn Drug and Alcohol team, also known as WNHS, for those who aren't aware. This is a statewide service. We have a very high number of Aboriginal patients that come to us for antenatal care. I'd like to acknowledge that many of these women and their families have had difficult or traumatic experiences in their interface with health and community services. Our team aims to engage pregnant women with our service as early in their pregnancy as possible. Early engagement is based on honesty and respect, builds trust and a strong rapport so that women and their families feel safe and supported to attend antenatal care. Having a positive experience, attending regular appointments often minimises the time needed to be spent in hospital away from family. Early engagement also allows us to provide lots of education and support to create lasting change. Wandis is a multidisciplinary team. We have social work, midwifery, psychological services, medical, women's health. We work really closely in collaboration with our Aboriginal liaison officers, dietitians, lots of other health services, both rural and metro. At a woman's first booking appointment with Wandis, we have an integrated assessment form. This assessment identifies drug and alcohol use history, current use, but we also look at psychosocial factors, family of origin, a patient's existing support network, what their pregnancy means to them, as well as psychological factors. This enables us to identify strengths that already exist. The biggest strength being that women and their families love their unborn babies very, very much, and they want good outcomes. Pregnancy is a massive motivation for opportunity for change. For this reason, mums-to-be will often tell us a little bit about their drug use because they want some help to address that. We will provide education and support to them in a non-judgmental way. Involving a woman's family and partner in this process also has really great benefits for mums and bubs. Before COVID restrictions, our patients would arrive at Wandis Clinic on a Friday morning with their partners, mums, sisters or aunties, and often a couple of kids in tow as well. It was great being able to meet the families, as this provided opportunities to educate not just women, but their support networks about drug and alcohol use in pregnancy and parenting. One of the best strategies for pregnant women to reduce or cease their drug and alcohol use is for the people around them to also make positive changes. It also provides an opportunity to work with families around how to support a new mum who's struggling to make changes, how they're going to help look after the baby, making sure there's a safe sleeping space for baby, things like that. It's become more challenging with the COVID restrictions that we now have to be able to engage with family and community in the same way. But we continue to see this as a really, really important aspect of our work. A lot of this we do now by telephone with the permission of the patient, but also regularly providing exemptions for women to bring a support person with them into clinic. Just to give a brief example, we recently had a young Indigenous woman in her first pregnancy. She came in with her partner in her first trimester. Initially, she was very shy and quiet, but bravely she came to see us. And her partner who came with her was very defensive about their quite heavy cannabis use. We explained very gently that we're not here to judge them. We're here to provide well-informed information and to work together so we can understand how we can best support both of them. It took time to build the relationship, but by the end of the pregnancy, they'd both ceased their cannabis use and they had a strong focus on the health of their baby and themselves as new parents. So some of the outcomes that we see for our Aboriginal patients are the reduction or cessation of drug and alcohol use by women and their families, an increased awareness of harm minimisation and safety strategies, and really strong family and community systems in place to support the health and wellbeing of new mums and their babies. Back to you, Danielle.
Wonderful. Thank you, Grady. So again, I'm hearing a bit of a common thread there between yourself and Dr. Scott. And what I'm hearing, and also Pushpa yourself actually, what I'm hearing is it's not only just not focusing on the isolation of the symptom and considering what the history is of that person, but it's also not isolating the person as the individual, but seeing them as connected to a social system. And providing a service from that point. I've also heard that intervening really early is the most important thing, and that has been come up in the last three panelists, and that's the thing that I hear that's overlapping. I wonder. I also want to acknowledge that your team seems to be using has found a form that the integrated form.
Integrated assessment form, yes.
Assessment form, that's right. And I wonder if there's any other part of the system that's not using something like that, that allows you to capture those sorts of information so that we can wrap around and consider all the factors out there. I want to give this an opportunity for everyone in the audience in the space with us to offer any comments on what you've just heard so far. If there's any questions that is burning that you'd like to kind of put out there, please choose now to put that forward. We do have Jane Warland, who's put a comment in the space, in the comment space. She's saying using language and words too, like Scott said. Did you want to maybe make a comment to that, Jane, a bit more, if you'd, not to put you on the spot, if you're in the space with us?
Yeah, I just wanted to appreciate that Scott was talking about the Noongar words for star baby. And he and I were working on that same grant and really getting an education from the Noongar elders who are working on that grant with us. And I think both of us were really touched by the use of that word, and we made the decision that we would be talking about star babies rather than stillborn babies in that space, because it's the language and the words that Aboriginal people use, and we're doing an Aboriginal study. So I guess it's just reiterating what Scott said and supporting what he said as that being a really important thing for people who are non-Aboriginal to do.
Thanks for that, Jane. Only because we do have a little bit of time to unpack a little bit with the audience in the space. How does that, does anyone want to kind of build on what that might, it's even, if it's yourself, Jane, or yourself, Dr. Scott, on what that's like to use language in that form when it comes to working with people? Does it bring a certain level of depth that's different to, per se, not using language in that way?
Yeah, Danielle, I've got a couple of things I want to just mention briefly. One is that language matters. Whether it's English language, whether it's Noongar language, whether it's language from other Aboriginal communities around WA, it's important. You know, when we talk about things being normal and abnormal, but when we talk about, you know, stillborn babies, which some Aboriginal groups find really difficult and confronting, and it's easier to talk about Jinder Mawin, about star babies. And one of the things that we know is one of our failings, not through want of trying, but more through lack of knowledge, really, is that the care that we provide that's so good is often culturally inappropriate and culturally unsafe. I mean, I get it. It's scary. It's culturally inappropriate, unsafe for an Aboriginal woman to come and see a big scary white man like me, regardless of my best of intentions. It's just not culturally appropriate. And I get that's where which is a challenge. And using language and just trying and being seen to try is half of the journey. One of the other things I wanted to say is just to acknowledge Jane, and I'm really glad you spoke, Jane. Jane's one of the great success stories of our health service moving forward. So Jane, I'm going to embarrass you here, but Jane's an internationally recognised stillbirth researcher. She is an absolute boon, a really strong recruitment for the organisation, and Jane really leads the nation and the world in stillbirth in Aboriginal women particularly, and will make great discoveries and great inroads into us. Really closing the gap in this really important thing. So welcome, Jane. You're a wonderful addition to our team.
Oh gosh, don't quite know how to respond to that. Thank you, Scott.
just to allow it to land, that's all. I'm sure you're worthy of the compliment. And it tells me that what we have is a bunch of brilliant and awesome people that work with us in this service that can actually stand up and make these changes now with each other. And if we only realise who each and every one of us are, then maybe we won't feel so alone, and maybe the load won't feel so heavy. And it's awesome to be able to be in spaces like that to realise. I will push us to our next panelist. Kelly, I'm going to bring you in now. Naturally, this kind of flows on from what one of the things that Dr. Scott has also said about equitable access. So your strategic direction is around equitable and timely access to the best quality and safe care. We can start to see how these strategies are starting to layer on top of each other, right? So what they're saying is common barriers to equitable and timely access to healthcare include waiting times being too long, care not available at the time requested, lack of health service in the area, transport and distance issues, lack of affordable services, poor environmental health conditions, and services are culturally appropriate as another, like whether or not they have met that as a level in their service, and that could be a barrier if they aren't. So they say improving the patient experience across the health system through better integration of services, increased collaboration in Aboriginal community controlled health services, and discharge planning and environmental health interventions is critical. It's in all those areas that they've identified that the work needs to happen. My question to you, Kelly, is what have you understood about these barriers, and how have you worked to successfully overcome one of them that exists in your space?
Thanks for that, Danielle. That's yeah, a nice big paragraph you've given me. So I'm the Aboriginal Program Officer with Breast Green WA. So we're obviously a statewide service. So we service all women within WA to give them access to having screening mammograms. I suppose for me, you know, I've grown up in a small town. I've lived in smaller towns. I haven't always lived in a city. So firsthand, I know how hard it is to have access to good healthcare. Whether, you know, you're not in the town when a service comes through, like I lived out in the Pilbara, and it was only once every 4 to 6 weeks that, you know, someone would come through back in the day to do your pap smears, so, or your cervical screenings now. So if you weren't in town, if you're in the next big town doing your monthly shopping, or you had to go somewhere else for whatever reason and you missed it, you had no other option but to wait another 6 to 8 weeks before that service came through again. So it is hard for people living and working in rural and remote areas. One of the things I suppose with Breast Green WA, which I love, is we have a mobile service. So not only do we have 13 fixed clinics that people can come and see in the metro area in Bunbury and Albany, we have 4 units that travel around WA. So I suppose we're trying to take out that transport and distance issue, the lack of not having that health service in your area. But again, like other health services, we only go through those towns maybe once a year, once every 2 years. So if you do miss them, then you probably will have to either come to Perth for a screening or go to your nearest town where we are. But with that transport issue, you know, I work closely with the community, with the Aboriginal health workers, just so they're aware of when we're coming to town. They know how long we're there for. We help arrange for transport, for accommodation. You know, we try and give the ladies like some food when they're coming in, so that way when they do actually come to our service, they're feeling comfortable and they're getting that service, and they're feeling appreciated that we've actually gone to the extra, I suppose, length and distance to try and get them in. One thing we did do last year was we had a couple of letters from like the CEO's CAMs and things like that to see, can we bring the mobile to community? Being what we do, you know, sensitive machines and all that, it's very hard to get out to every remote Aboriginal community. But fortunately, we had sealed roads going out to Bidjadanga and Lombardina now up the peninsula. So we're actually able to take our mobile to Bidjadanga community and up to Lombardina to screen the ladies of like Beagle Bay, Juttagen, Lombardina and One Arm Point. That saved those ladies travelling 2 hours one way to Broome and then 2 hours back again for essentially a 15-minute screening appointment. it really made a big difference to the ladies in the community, which meant they literally could walk out their door and come and see us, and then they'd be back home within 20 minutes instead of that, 4-hour journey plus the screening time. So say if we screen 15 ladies in Broome, they've got to sit around and wait for every single person to be screened to get back on the bus and then back to their community. So I'm really happy that we're able to take it. It's unfortunate that we can't take the mobile to communities where there's no sealed road. But speaking with the ladies of those communities and the health workers, it made a big difference. Like, it made the ladies feel more at ease to know that they could just walk out the door and have the service there for them, which they're not used to, because obviously if you need a service like that, you normally have to travel a long way. I still deal every 2 years with ladies that come out from the lands. I meet them in Laverton. They've travelled up to 15 hours literally to come for a 15-minute appointment. So, while we're trying to remove some of those barriers, unfortunately, some of those barriers are going to be there for a very long time. But we're trying our best to try and figure out how we can make it a little bit more easier and more comfortable, and just so the ladies know that we're there for them and we want to, help them as much as we can. Back to you, Danielle.
Thank you, Kelly. Wow, it's amazing. Even though you feel like you have already all acknowledged that there's a lot more work that you need to do in terms of other spaces or areas that you're not reaching, it sounds like that you've basically been able to solve the problem for most of the people that you're not reaching, and it's just that little bit more that you've got to kind of work around in terms of overcoming that problem. I just want to congratulate you for being able to achieve problem solving such a huge amount and only having that little bit. And I want to put it to the audience. I mean, we're a statewide service, right? Mostly, like if we're not going out across the state, then people across the state are coming to us, right? So what does that look like when we can overcome the barriers of the structure that limits us to work as a statewide service like that? I wonder, that's all. What does it look like when it comes to having mobile midwives? Just some thought. We'll move to the next panelist. Unless there's anyone who wants to ask a question, please do raise your hand or make it known. We'll come to you. So our next panelist is Kylie. I'm going to bring Kylie in. Your strategic direction that you're working on is a culturally respectful and not around the structures of the health system, and how do we change, what do we need to change, and how do we change it too so we overcome it. What they're saying is experience depression and anxiety and health risk behaviours such as smoking and harmful alcohol and other drug use. So basically their bad experience of a service is increasing all of that. They say building the system's capacity, capability and responsiveness to prevent and reduce systemic racism can be progressed by improving the cultural and language competency of health services. Look at that thing coming through. The languages is important, right? My question to you, Kylie, is how has your team understood systemic discrimination, and is your team achieving a culturally respectful and non-discriminatory health system? Tell us how you've been doing this.
Okay, thank you, Danielle. I'm going to hope that I'm not going to freeze, because I have sat here beautifully through all of this and listened to everyone, and just as you started to ask me that question, my computer went, ooh. So good thing I know what you were going to ask me. I also would like to acknowledge being here on Wajak Noongar Budja, and I would like to take a moment to just say that everybody who's spoken ahead of me has just amazed me. We have so many brilliant things happening across Women and Newborn Health Service, and it's exciting to be a part of a larger team that is doing its very best to change service delivery and to get better outcomes for Aboriginal women. And it's really, it's an honour to be here amongst you all, and I'm really glad to be talking to everyone today. Systemically, for those of you who don't know, the agency that I'm the manager of is the Sexual Assault Resource Centre, and systemically we know that Aboriginal people experience sexual assault at far greater rates than other members of society. And in fact, the Australian Bureau of Statistics tells us that Aboriginal women are 33 times more likely to experience sexual assault across their lifespan than non-Aboriginal women are in Australia. And that is a pretty horrific number. Our team here at SARC provide a number of different services. One of our services is aimed at providing medical, forensic and crisis counselling services to people who've had a recent sexual assault. But at the same time, we have a big division of staff who are dedicated to providing trauma therapy to people who need counselling and recovery after experiencing a sexual violence experience across their lifespan. So one of the things that we have here at SARC is a really good hit rate for success with trauma recovery counselling. We're very good at it. We've got excellent staff. We see a large number of people, but I tell you what we don't see, very many Aboriginal people. And if you think about that fact that Aboriginal people are more likely to experience sexual assault, and then you think about the fact that not many of them come to us for trauma recovery, you have to wonder what's happening in that space. And I think it's important to be able to identify the resilience of Aboriginal people and the strengths that they have as a community and as individuals. But I think it's also important to look at ourselves as a system and figure out what it is that we are doing that dissuades people from seeking help from us as a service. So across the last couple of years, SARC has put a huge amount of effort into that. We've done a lot of staff education around working in culturally appropriate ways, and particularly in establishing rapport in a counselling setting with an Aboriginal person. And we've also had a big review of how referrals come into our service. And one of the things that became clear as part of that process was that we had a system that was set up with a very clear inclusion and exclusion criteria. Now, that inclusion and exclusion criteria was never designed to be racist. It was not meant to discriminate against people. It was meant to pick the people who could get the most out of the service that we were going to offer so that we could have high success rates. However, that inclusion and exclusion criteria includes people who have acute mental health crises. It excludes people who have drug and alcohol issues and homelessness. And it excludes people who have stability problems where they're not sure where they're going to be living or how they're going to be supported from one day to the next. So without intending to, there are a very large number of Aboriginal people who meet some or all of those exclusion criteria. And that makes it really difficult. On top of that, when we are offering therapy here at our CBACO offices, you come indoors, you meet one-on-one with a therapist, and we ask you to talk about your individual need. Now, if you spend any time with Aboriginal people and ask the community what's necessary, individuation isn't kind of the problem. A lot of the time it's about looking at the entire system, and it's about looking at how the family works together to resolve issues, and it isn't done indoors one-on-one with the therapist. The other issue is that we ask people to articulate their trauma, and that can be very shameful and very distressing for Aboriginal people. So we went through a big review where we determined that if we kept doing what we have always done, we would always continue to have very few Aboriginal people accessing our services for help. So in spite of all of the education and training, we figured that wasn't enough. And so we went through a process of reviewing trauma therapy models. And we came up with we kind of invented our own little model that was based on a few existing validated evidence-based protocols. We looked at flash EMDR, which is a type of eye movement desensitisation, and we looked at Gestalt therapy. And we looked at the potential for people to recover without articulating what their trauma was. So if you don't have to say it out loud, but you can still get some relief from the symptoms of post-traumatic stress, then that has to be a bonus for people. We worked really, really closely with the Aboriginal community to try and figure out how best to deliver that service and where it could be delivered. And one of the things that we moved away from was providing trauma therapy services for Aboriginal people here at CBACO. We actually moved towards doing that in some of our outreach clinics, and we opened a pilot clinic in Rockingham, which sits on a different type of land for Aboriginal people that has a different use. And we work really closely with a community agency called Babinga Maya to pilot a new way of providing trauma therapy to Aboriginal people. That new therapy program has been incredibly successful. We've been running it for just on 18 months now. We've seen more than 60 Aboriginal people through that program. We've had feedback from everybody, and we operated really using a safety and quality plan, do, study, act cycle, so that we were taking feedback all the time and trying to improve and to make things better. And we're offering a completely different type of trauma work for Aboriginal people that is specific to their needs, that doesn't require the regulations and kind of, you know, all of the kind of strict kind of health department stuff, but allows people to come into us as they feel that they can and access what they can when they want to. We learned lots of things along the way, and lots of the things that we thought that we were doing when we started this process were fundamentally based on incorrect assumptions. So, for example, we're often told that Aboriginal people work on bush time, on different time, that they show up when they want to and they leave when they want to, and, you know, there's no kind of structure of time. We learned very, very quickly that that assumption is false and absolutely inappropriate for the Aboriginal community. They do need appointments, they do need to know how to plan their day, and they do need to be able to take into account a whole range of other competing demands. And if you work with those competing demands and don't put pressure on people, you can actually have a much better outcome for their attendance. We've done remarkably well with our program and we want to continue to offer it. We've been a little bit interrupted by the pandemic, but we have big lofty goals that we want to open this clinic in a couple of other places with a couple of other agencies and kind of spread our service across the metro area. And we have also gone the extra step of working with our directorate and with Nicole Flint as our co-director to transform some of our existing FTE into 50D FTE and to actually look at bringing in Aboriginal workforce to help us to run this program in an even more community focused way. It's been a huge opportunity for us to make a difference to people's lives. And it's changed the way that SARC functions across the board. And I think that systemically, we have learned so many things just by listening. And I think that's the really key message that I would want to give to everyone. You know, I feel like there are some synergies between lots of the things that Scott and Kelly and Grady and Pushpa have raised. But I think that my big message that I'd like to give to everyone is if you want to be brave and you want to make change for Aboriginal people, stop talking and start listening. And back to you, Danielle.
Thank you, Kylie. Very good. Wow. So I just want to acknowledge that sometimes a lot of these things to be brave and to make change, it can feel like it's a really big job. But what I just heard there was it's not such a big job when we start to look at ourselves. Let's start within, and then we start to work with. Yeah. So. Very good. Thank you. Lots of listening is involved in all of that, and not just listening to other people, but also listening to what we're learning within the structures of our system and acting on that. Right. If there's no one who wants to make a comment or jump in with that one, I'm going to push to our final panelist today, which is Storm. Storm, I'm going to bring you in, and perfect because Kylie has mentioned the word workforce, and this strategic direction is completely and totally all about workforce, which is to have a strong, skilled and growing Aboriginal workforce. And what they say is Aboriginal people bring the health sector a diverse range of skills, including the ability to break down barriers to access and bring cultural perspective, which help meet the need of Aboriginal people. They also say a non-Aboriginal workforce that understands and respects Aboriginal people's perspectives and reflects this in their day-to-day involvement with Aboriginal people is important. Fostering a workplace culture that supports and respects the knowledge of its Aboriginal staff is paramount. So the question that I have for you, Storm, is do you have an example on where you can share of when an Aboriginal staff member was supported successfully, and what message do you feel is most important for us to hear?
Okay, thank you, Danielle. Thank you all for saying what you said. I thoroughly enjoyed listening to everyone's story. And yeah, feeling pretty cool to be in this space with everyone. So in terms of me, for those who don't know, I am the workforce consultant for Aboriginal employment for North Metro. So looking at the workforce portfolio of our Aboriginal staff across all of our hospital and sites and services. Indeed, with the workforce strategies to grow and upskill and have Aboriginal staff in all areas of leadership and decision-making roles as well. But keeping in mind that that's only one part of it, where my passion and my experience, where I feel the biggest gap is to create those spaces for Aboriginal people to do their jobs the way that they do, because that's where we get the results that we are needing, that speak for community. And I hope that I make sense and that I'm not too wish-washy with this. I will try and stay on track. In regards to your question to me, Danielle, in terms of the example I have, there are a few examples that I have. I wish I had more, but I'm going to use one. So understanding, and I guess I'm following the context of this conversation so far, understanding the history and the lives that Aboriginal people live today is quite important when we as professionals are supporting and engaging and are trying to sustain our Aboriginal workforce, right? Because all of those other considerations need to be taken into account. And I refer back to what you said, Kylie, you know, looking at when we say, you know, Aboriginal people work on black collar time, it's like, no, we can make appointments. We just need to understand that they have competing priorities, right? And the exact same is for when Aboriginal workers come into the workplace. What are the competing priorities that Aboriginal people, Aboriginal workers have to take on to maintain the role, to keep the role? We have so many external things that are competing for that, right? And all of us spend most of our lives at work, or at least a third of our lives at work. It's a pretty big chunk, right? I'm going a little bit off track, but I trust that I'm going to answer the question. I often have managers, executives, directors come to me asking for advice around certain situations. And one of the patterns that I've been noticing is this acknowledgement to say, you know, how do I generalize this? Acknowledging that they don't have a lot of the barriers to consider, right? When they come to work, they have a nuclear family, they have work, and then they have their personal lives. It's someone, yeah. A few people actually have referred to it as vanilla, compared to when trying to support an Aboriginal staff member, that there are just competing factors that are not relevant to a non-Aboriginal person, and therefore they don't understand how they can help and in what capacity, right? And with all best intentions, what can we do to support this person? And I've been reflecting on this little pattern and on this acknowledgement. And I think what I kind of sat with is that really what we're looking at is privilege and not having privilege, right? All of the barriers that come with our history and our context around that. Also linking back into language is quite important. We often in our workplace within health, you know, have this concept that we have Aboriginal community that we want to employ so that we can then grow our Aboriginal workforce, right? So we have community, we have workforce or staff. They're both the same. They're exactly the same, because when Aboriginal staff go home, we are the community, and that doesn't stop, right? And when we come back into the workforce, we're not workers, we're still community. And so there is no divide. And essentially across the board with all of our services, whether it's, you know, prevention, whether it's drug and alcohol or maternity or childbirth, there is no us and them, because we flow in and out of the service, in and out of community, in and out of the profession. We are one. And so when we are talking and looking at and asking the questions on strategically, systemically, how can we provide the best and the right support for our Aboriginal staff and or community, is what often is not said. My take on it is really about understanding that context of all of the barriers that come with, and applying a human approach to it. And I'll get to my experience examples soon. Applying a human approach to it, in the sense of not just looking at, you know, what awards say we can and can't do, what are the guidelines, what's black and white, what's yes and no, and leaning into spaces of not necessarily what can we do to support you, rather what do you need and how can we kind of make that work. The example that I'll provide now is we had a young person come through one of our career pathways who in the end was not eligible, but this person had reached out to me on the side and said that they really want to continue to try and get employment, or what other avenues is there, because we had to decline this person through that certain pathway. So I had reached out to one of the directors and said, look, I really want to accommodate this person. They are showing interest and initiative and right? So we get this person in, we take them through the recruitment selection process, all of that. Another barrier had come up. What do I say about this? Okay, another barrier had come up and we had to make a decision. Are we going to continue with this, or do we review it? Now on paper, it would have been a clean cut. No, we can't take this person, right? Again, considering the context of the lived experience of a young person, from whether their childhood, their adolescence, and then, you know, making their way, those transition periods, making their way into the workforce, and something of themselves as well. The director and I decided to lean into this space, create a space for that transition period to listen and to find out what the context was. So we invited this person in to come in and tell their side of the story. And they courageously did. And they were thankful, we were thankful that this person did as well. There were some hard, raw questions that we had to ask in this interview. And, you know, they provided us with an insight with their story. And the decision for us was either to trust moving forward, taking a leap of faith to continue to employ this person, or not. Now, like I said, on paper, it would have been a clean cut no. Anyone reading that would have said no. But we advocated up to ED level to employ this person, and we would put in certain mitigation, whatever around that, and extra support. We have not looked back. This person is still employed, doing an amazing job, loving the job, and is a huge asset to the team that they're currently in. And so, you know, for us to be very mindful of profiling on an instance, yes, but not basing a decision just on that. And, you know, I think this goes without saying, we all know this, right? But I guess what I'm saying is that be courageous enough to see ourselves as the tools to get around what we need to, and so that we can actually have a service that has a human approach, not just a systemic one that continues to, in its own way, disservice us as human beings, whether we're already marginalised or not. And so my role in workforce is really looking at working closely with managers, executives around understanding the context of people as human beings as well, not just within the Aboriginal space, because at the end of the day, all of those underlying principles relate to all of us, right? So yeah, and just a bit of, I guess, education around the Aboriginal space. So Aboriginal people have a sense of being rather than doing. Now, when we come into our workplace, the system that already exists when we walk into our workplaces has a sense of doing rather than being. And so we're constantly, you know, not fighting, but we're moving with this force that contradicts and creates conflict. And I'm sure for many people as well, around a sense of being and delivering versus just doing without substance. And I hope that makes sense. But that's kind of where my passion lies. So I will leave it there and I'll hand it straight back over to you, Danielle. So yeah, thank you.
You're on mute, Danielle.
Who mute me? So my apologies. What I was saying, it was, thank you so much, Storm. I know that we're 3 minutes over now. I just felt like that was really important to allow Storm to finish that. I'm glad that I did. I feel so full and feeling all my humanness now after hearing that. So thank you. Just to kind of sum that up, what I heard was basically it's not just working with the individual. Again, it's about considering the context and allowing people the chance to tell their story so that we can understand what has happened when it comes to anything that shows up on paper. And then, you know, we find ourselves feeling super glad that we did that because, you know, we've got a person that's so successful who's still here doing the great work. It seems that a lot of people are just happy to absorb the information today. There's no questions, and I'm pleased to just allow you to eat this all up and just, you know, be celebrated because we are doing such a good job. I hope that today has re-inspired a newfound motivation in you to be brave and to make change in some way. I do want to surface that our peak body in Reconciliation WA at their virtual breakfast this year, they placed a call to action out, and they said for us to strive to be global leaders in reconciliation who ensure all children are able to fulfill their dreams without sacrifice to their culture. And I hope that the re-inspired motivation from today's panel moves you to accept that call in whatever way that this looks from the perspective of health and in whatever form that our contributions may take. So this brings us to the end of the panel this year. A big thank you to our panelists and to our audience. And know that the conversation does not end here. Before you leave the room, please do unmute yourself and join me in thanking our 2022 panelists for this year. Everyone's clapping. We can see claps.
Everyone.
Thank
you. It was amazing. Thanks to all of you.
Thanks, Danielle.
Thank you all.
Thanks, Daniel.
Thank you. Got a few still hanging in.
Danielle, I'm going to have to run. I've just realised it's school pickup time.
Oh,
I'm getting screenshots of you, Danielle. So smile, everybody. I'm going to get a screenshot right now. Perfect. I've been waiting for the right moment.
Beautiful. And I just before you're going to get a gift. Thank you for coming. That's all I can say, and you can go and do your school pickup. I'm going to chase you down and give you a gift.
Okay, I'll come over and visit you soon.
Thank you. See ya.
Thanks, everyone. It was great.
Thank you. Ah, how wonderful are you all?
Well done, everyone.
Thanks, Christy.
Awesome stories, everyone. Thank you.
Well
Yes.
organised, Danielle. You did a great job.
Oh, thank you. It wouldn't be as successful without you. So each and every single one of you have done a great job. Wasn't sure how this was going to plan out. First time being on the online version, and I think we pulled it together pretty good. I always trust that, you know, spirit is at work there for us. And it was just amazing to see how it all unfolded and how these strategies do weave and overlap with each other. It was nice to kind of hear each and every one of you kind of just reiterate what is important and what is needed to make change in the different lenses that we spoke to today. Yeah, I just want to ask if you give you the moment to kind of share some thoughts on what that was like for you.
You did a great job, Danielle. What I really loved is the background and the theme. Awesome.
Yeah, thank you. I just want to say, job well done. You're like, even in the preparation to it, so good. Loved hearing everyone's stories. Thank you for letting me be a part of it. And yeah, good stuff. It's not easy doing stuff like this online. So yeah, kudos to everyone and to you, Danielle.
Yeah, thank you.
Well done, everyone. And Pushpa, you were super brave. You went first.
Oh, I never thought she'll choose me first.
Gosh.
I knew what order the standards are in.
Yeah, Kylie's got advantage on you, Zor. She's next door to me, so yeah. If no one else has anything, I know Grady hasn't had a chance to start. Maybe you have said, Dr. Scott, you haven't. I just want to give you the opportunity to make comment on, you know, any improvements that we should, you know, kind of build on.
I think you did an amazing job, Danielle, organising everything and supporting us to be, you know, on track. So I really appreciate that, and I really enjoyed listening to everyone's stories. I feel really inspired.
Oh, nice.
Yeah, me too. I look. Thank you very much for the invitation to be part of this. I've really enjoyed it, and I am always impressed by the amazing work that people around our health service are doing. So it's easy to focus on things that are not going well, and I think it's nice to step back and think, hang on, we actually do some really good stuff. Thanks, Dana. I do lots of these sorts of things, and it was really, this is the easiest one I've ever done because you've just been so supportive and helpful. Thanks very much, and beautifully facilitated. Well done.
Oh, thank you. Oh, so good. Thank you so much. I will share with you. I know I did a quick rush job. You're each going to get a tree as a gift to show our thanks. It's called the Mungat tree. It's so in English way, it's a roseberry jam wattle. I'll read it out to you. So it says, this tree had several uses in Aboriginal food and lifestyle, producing resin and seeds for food and hardwood for tools and weaponry. In Aboriginal cooking, the edible seeds were traditionally ground into flour and coal baked into small cakes. So the famous dampers that you would all be so familiar with. And the wood is dense, beautifully grained and termite resistant. The flowers attract bees and native birds. The tree is a nitrogen fixer, effectively sucking nitrogen from the air and installing it into the soil around its roots. So I don't know if any of you know, but there's a big soil problem in our world at the moment. And so this is a nice remedy for it. And it says that it provides food for surrounding plants such as guangdong and sandalwood, making it an excellent companion or host species.
I am so super excited right now. Maybe a little too excited about this part, just saying.
I love the bush tucker plants. They're amazing.
Yay! Yeah. So we thought stick to the theme because we were all giving food for thought today. We thought we'd give you a tree that produces some food. What I'll need to do is obviously track you each and every single one of you down so I can hand you your tree. And if you don't have a green thumb, maybe call on someone in your family that can help you to nurture and grow this beautiful tree that will take a place in your lovely homes.
I don't know if any of you have noticed, but we've got some lovely emails starting to trickle through to us. There's a really nice email to the entire panel from Graham Boardley thanking us for our contributions today. It's really, and I think it's really important that we acknowledge all the hard work that went into the session, but also the great work that was presented today. I think well done to all of you.
Yeah.
One more thing, Daniel. Without any hiccups, technology-wise, we did it. So
Yeah,
usually in the
It's a win.
form,
Yeah.
you get a lot of hiccups.
I got a bit scared when my screen froze.
Yeah. Oh, see, when we're doing good work, all things will move out of its way, right? Oh gosh. All
Danielle,
right.
you at SARC, I'll come for a walk. It's nice to get out in the fresh air. I'll come and pick up my plant. I'm excited about that.
Oh, yay. Yes. Awesome.
Can I come now?
Yeah, please. I will be eagerly waiting for your presence to arrive. All right. Yep. Sorry, Erin.
So no, that's okay. I just want to say how
Yes,
incredibly
you too.
privileged I feel working for Women Newborn Health Service. It's incredible what all of you do, and it was incredible to be listening to everything you're doing as well. So yeah, really, thank you. From generally speaking from the community, it's incredible. And I was really glad to be here to hear you share it. And like you said, Scott, it can be easy, especially during the pandemic, to be concerned about, what's going wrong or be overwhelmed by those. So it's fantastic that, we remember to focus on the good things that our service offers and does, and, celebrating that and continuing working towards it, expanding on it. And yeah, some great heroes in this health service. I really hope you genuinely believe that. Yeah.
Oh, wow. Thank you. And thank you, Erin, for all the background support. This wouldn't have gone as smooth as what it would have without you. So yeah, know that you're someone who is a big part of this being successful today as well. So yeah, beautiful. We won't keep you any longer. We'll let you let's set you free to whatever it is that you have to do for the rest of your busy days. And if it throws you back into your chaos, please promise me that you'll do those 3 deep breaths before you go home and just like collect yourself and ground and find that humanness that I experienced Storm bring into my awareness today. Awesome. All right.
Thank you.
See you, beautiful people. Use a bunch of
Bye,
legends.
everyone. Thank you.
Bye. Bye.